Wrong one. Hmm. Hello, testing 1, 2. Testing 1, 2. 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 Hi, Azadeh, are you there?
Hi. Hi, John.
You can talk, Azadeh. Don't worry. I mean,
Oh,
this is
sorry.
like being in the lobby
Yeah,
of a classroom, outside the classroom.
yeah, sorry.
So we can talk like, regular people.
Yeah, because people in my home are asleep. I can't talk so loud.
Oh, okay, okay, all right. Okay, I won't talk then. I'll keep my words to a minimum. Well, I'll just explain what I'm doing. Okay.
Okay.
Uh, basically, let me shut this. Hold on. I got three computers. I gotta get the sound down.
Yeah. Can you hear me?
Yeah, I can hear you fine. You sound like
You know,
you sound quiet.
yeah, because I changed my internet and my webcam has a microphone.
Oh, okay.
Yeah.
Okay. You have no camera, huh?
Yeah, right now because
You
my
don't, well, you
because
don't have to
people.
put it on if you don't want to. That's okay.
Yeah.
Uh, okay. Well, basically, what I'm doing is making sure the sound is on, the people aren't having
Okay.
problems getting in, and
Yeah.
let me make you the co-host. You'll be able to see. I may
Okay.
get another co-host. I'll let you know. And what that does, you've done it before, right?
Uh, yeah, but
Yeah, you look at the participants on the right side. Do you see them?
yeah,
You got to make sure they're muted if they're not speaking,
yeah, I know.
because sometimes people come in, they don't mute, and it makes noise. And
Yeah, I
it's
know.
just you've seen me do it. I
Yeah,
missed a few that come in. So
but I don't see participant in right hand of my screen.
okay, okay, whatever. Okay, so we'll see you later. Just watch and mute people, and just see how it works,
Okay.
basically. And well, you really can't talk, but after
Yeah, I
I
can see that.
I
I can see that.
I think after the conference is a good time to network
Yeah,
for people like you that want to meet the speakers.
yeah.
But you don't have to. I mean, you can be quiet.
Okay,
Okay, I'll be back later.
okay.
Hello, Ahmad. I'm going to step away, Ahmad, like as you have probably. Okay, hold
Um,
on. Let me put my screen on. See, there's a way I can put a nice screen share on. See the one I have now? I pin it. That way it gives something, as a day, this
uh,
time we can run commercials. I mean, right now we could have a slideshow of like
okay.
the
Okay.
coming events. You know what I mean? Like at the movies.
Yeah.
You know how they have, reels you can watch what's coming up and stuff,
Yeah.
or something like that. We can do what we want. We got it in the screen, we got it in the station, and they left the keys in the station, and we took over.
Yeah.
Hey, Ahmad, I see you.
Yes, sir. How are you?
Yeah, I don't have my camera set up yet. How you doing?
Very well, very well.
Okay, we have
دكتور عماد how are you؟
هلا هلا, how are you?
هلا دكتور عماد، لك هلا بجبل العرب كلها.
أهلين أهلين, كيفك؟
لك على راسي دكتور عماد، كيفك؟ طمنا عنك.
يا هلا يا هلا.
هلا جبل العرب كلها.
وين أنت بحلب هلا؟
والله حاليا بترماني ادلب.
كيف الأمور عندك؟
والله نحن بأي ناحية شخصية ماشي حالي، ما لي علاقة بغيري. بس.
That's great. That's great.
حاج
Well,
بكفي.
this is Omar, no? Omar, he promised he will not smoke in front of the camera.
Oh, well, I was gonna mention the rules.
How are you, Professor Ali? How are you? Dr. John, how are you?
Yeah, good. How you doing, Omar? Welcome.
Okay, thank you very much for you all.
So no smoking during the telecast. No,
No, they can do whatever they want. Just close their camera.
That's right.
Stop smoking. Stop smoking.
No, before the telecast, it's okay. But once it starts, no smoking.
Okay, stop. Okay.
Hello, Robert Otero Moya. Hello, everybody that wants to say hello.
How are you
doing?
John? How are you?
There he is. There's Omar. I gotta get this camera.
I'm fine.
straight up.
Now, John, you have the capability to make somebody as a panelist whenever he enters, or you need to make him each time?
Each time, like someone trying to come into the webcast, you mean?
Yes.
Yeah. Either me or my co-host.
Oh.
Azadeh, are you there? Azadeh, she's from Iran. She's a student from Iran. Azadeh, are you there?
Hello.
Yeah. Her job, Dr. Ahmad, is basically to mute people if we miss them.
Okay.
Yeah.
You know how we make the mistake. Sometimes people don't mute, so so her job is to mute people. Okay, Azadeh, you know how to do it, right? How to mute people?
Yeah, that's okay.
Keep an eye on people that come in, because sometimes they forget,
Okay.
and there's really no need for their audio to be on when they're coming in. There's no need. Only when they want to. Only when they want to talk. So, and also that brings up a point. When people come to be admitted, sometimes I'm not paying attention and they sit there. So when people come in the waiting room, you know what I mean, Azadeh, right?
Yeah.
You admit them, admit them, you know, like it says, admit person. Okay.
Okay.
So that way, if I see him first, I'll do it. But sometimes I'll be working on something, I won't see it.
Yeah,
and,
I know.
People will get frustrated because they can't come in.
Okay.
But this is a pretty simple, usually, you know, we just have one couple of speakers. We don't have people coming and going, What you do
Yeah.
sometimes in the big webcasts, you have people coming and going. You got to kind of coordinate people coming and going.
Yeah,
Speakers especially.
understand.
Anybody else want to say hi and introduce themselves? This is the time to network. If you want to see people to get to know your face. Hello, JP. Hello, Vasish. How are you? Could you please introduce yourself if you want to? JP, who are you?
Hi, good night. I'm a neurosurgery resident from Montevideo, Uruguay.
Oh, excellent. Bienvenidos.
Thank you. Glad to be here. Thank you very
Great.
much.
Great. I'm glad you came. Okay, Vasish, how you doing?
My name is Arnold Bennett. I'm one of the residents from Microneurosurgery Institute from Dr. Lawton. I think we share the same link. Dr. Lawton's fellow, Vasish, set it up. So many of us will be coming under his name because we don't have a registration. We just we shared this link for Dr. Lawton to have the talk. So I'm very grateful that we have this opportunity.
Oh, you're welcome, and all your resident friends and whoever are welcome. Just give the link out. They're all welcome.
That's what happened. So there's going to be a bunch of us under the name of Vasish because he had the registration for us. My name is Arnold Bennett.
Great. You know, I think eventually, once we get better at this, because it's like a surgical instrument, when you get better at it, the more you use it. I think we'll be televising to classrooms, which hopefully a lecture like this has, two big names. Hopefully it'll go to a classroom in Uruguay or a classroom somewhere in Syria. Do you know what I mean? So that, that doesn't have to be of course, individuals are welcome, but classrooms are even better. So anyways, I think that's where the future is going to go, televising to classrooms.
Dr. John?
Yeah. Yes.
Dr. John?
Yes.
Any Kahoot today? Any Kahoot today? Question?
I'm not sure, Ahmad. How are we going to do that? Do you know what we're going to do? Oh.
What do you mean?
Questions, like just let them run it, and they'll determine whether they want to take questions.
Just as we said, questions written on the chat, and we will, put the questions together and let them answer. Because
okay, I'll say that. Put the question.
No question. Kahoot.
Oh, no.
Okay.
No, just write the questions in the chat.
Thank you.
In the chat.
Okay.
Omar. We got 18 minutes.
Because Professor Krisht just finished a huge cavernous sinus tumor. We just finished, and there is something else coming later at 38. So,
well, Dr. Krisht will be busy.
yeah.
But he'll be here, right?
Yeah.
Oh, okay.
Just finished that tumor.
Oh, okay. Okay, we started 15 minutes. Changing the background to get one that says I'm not starting soon. Sure. It's small. Dr. Macadam from Uruguay. Perhaps he stepped away.
Still here.
Yeah. We got to get Alvaro Cordoba to come to these.
Sorry?
Alvaro Cordoba, is that his name? He's a neurosurgeon that plays the guitar from Uruguay.
Exactly.
Can you hear me okay? Perhaps not. Hello, Lee.
Hello, Mr. Bennett.
How you doing?
Yeah, very good. You did a haircut?
Yeah. I feel faster.
Yeah,
I needed
good.
to work. I needed to work faster.
Very good.
Yeah. I contacted neurosurgery news.
Mm-hmm.
We haven't talked specifically, but he's probably the best person to go to for translators.
Yes,
like you said.
Yeah.
Yeah.
They have a lot of translators.
Man, they televise a lot.
Yes.
in China, right?
Yes. He is a key.
It's pretty popular in China, right?
Very popular, yeah.
Yeah, wow. I looked at all the videos. Wow. There's so many ones.
They still have an app.
They just do a couple a week. They do a lot every day in Chinese, of course.
Yes.
But I have some ideas about. You mentioned the people that the general neurosurgery public would want to hear in China.
Mm-hmm.
In China, so we have some ideas. I'll write to you about them. Okay.
Yes. Very good.
Yeah, because we'd like to give you what you guys want.
Yeah.
You know, whatever you demand, because I couldn't believe the numbers, the big numbers. Wow,
Yeah.
17,000 visits because it measures the visits on the video.
Yes,
You know, not just live, but after it's over, they count. You know how many people visit the.
Yeah.
So that's where 17,000 came from.
Yeah, the Chinese people love to learn.
Yeah. Oh, my penny. Move pen there. So, are you getting ready for spring football? You're not a big fan, right? Of Arkansas football.
Yeah, very good grass now.
Yeah, it's crazy, huh? The training now, right? In the spring, Arkansas, right?
Yes.
But it's not. They still play exhibition games, right? They play like exhibition games. Yeah, that's what they call them. That's big football.
Yeah.
They're very serious about football, right?
Yes.
The Razorbacks. Do you know the school song? Do you know the school song of Arkansas? No.
No.
How you doing, Mike?
Good. How are you, John?
Good. I guess Allie's coming from surgery. Get the background straight.
Got the wrong camera.
No, it looks good. Looks good. What, do you have a couple of views of that or a couple of?
Yeah, I got a couple cameras.
Go ahead, try them out. Try them out if you want. We've got a few minutes.
Yeah, it's weird. I'm just not seeing one of them.
Here's Dr. Krisht. Hello, hello, Ali. Can you hear me, Ali?
Yeah, I can hear you.
Oh, okay, good.
Just got on.
Welcome.
How are you? Hi, Michael.
Hi, Ali. How are you?
Good. How are you?
I'm okay.
Good.
We got 5 minutes.
Sounds good.
Hello, everyone. Hello, Professor Krisht, Professor Lawton, Abud. Nice to see you. Try, my friend.
Hi, Matthias.
Hi, my friend. Hope
Where you from?
everything
Where you
is good.
from, Matthias?
I'm from Brazil. The middle of the chaos with Corona, but we are okay.
Welcome.
Thank you.
Hello, Mateus.
Hey, Professor.
Yeah,
Everything okay?
good. Yeah. We are better than Brazil.
For sure.
Yeah.
The things are crazy. Huh? The government are bad and the people are bad too. It's a bad combination, you know. We don't have intensive care this week. We don't have surgeries. All the intensive care is completely full.
Oh,
Yeah. The anesthetics is finishing. Problems. The public and the private hospitals are all crazy. Difficult times.
yeah. Well, stay safe. You already had COVID, right?
Yeah. I already had COVID and the vaccine.
I see.
Yeah. But the vaccine don't, I think it only protects to bad cases, but you still have the disease and pass to other people. Difficult. And here in the United States, it's getting better.
Yeah, it's getting better.
Yeah, the vaccine's spreading out pretty good.
Yeah.
In Brazil, just a few people, I think 5% or 7% of the population still with vaccine. Only the professional, the health professionals, and I think it's about 70 up are vaccinated, but
I see.
Okay, 1 minute. A few more people coming in late. Okay, ready to start. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. I have the pleasure to be hosting the Achieving Mastery in Aneurysm Microneurosurgery with two gentlemen everyone knows, Dr. Ali Krisht and Dr. Mike Lawton. Okay, I'll turn it right over to Ali. Hello, Ali. You're muted, Ali. You're muted, Ali. You're muted.
Okay, can you hear me now?
Yeah, okay.
All right. Well, good evening, everyone. This is our fifth session, and we will be covering the basilar apex region aneurysms. It's one of those aneurysms that in many places they have been considered non-surgical aneurysms, and there are very few neurosurgeons who are still doing them. And I wonder whether you can even count them on one hand where basilar aneurysm is being done. I think there is a strong argument for why they should be considered for surgical intervention. And today, between myself and Dr. Lawton, we will be covering some of these thoughts and approaches that will make it safe to address these aneurysms and achieve even higher chances of cures in patients. Because the problem with these aneurysms is when they recur after many endovascular procedures, they really turn into malignant aneurysms, which means an untreatable and with a lot of morbidity. So I'll let Michael start the first half an hour, and as we mentioned before, Michael needs no introduction.
Mike, you're muted. I'm sorry. Michael, let me unmute you. Let me get you there. Mike, can you unmute? Can you hear me?
There, can you hear me now?
Yeah, now, okay.
Okay, hold on. Let me just change my name too. For some
Okay.
That's Ahmad.
Sorry.
Okay, there we go. All right, so can you hear me and can you see me?
Okay, both. We can see you and hear you.
All right, I'm going to hit play here, and you should now see my.
Perfect. Yeah, perfect. Perfect.
Okay. All right. Well, thank you, Ali. As always, great to see you. John, thank you for hosting. Yeah, this has been fun. This is, as Ali said, the fifth in our series of a half a dozen of these. So we're nearing the end. But I think this is one that's a special one for Ali, I know, and for myself too. I think both of us love this aneurysm. Both of us are almost crusaders about this aneurysm because, as he mentioned, I think in many centers, many top-notch centers, this has been a forsaken aneurysm that nobody's willing to touch with open surgery. And I do agree with Ali, it's a wrong stance to take. There's a certain mystique about it. There's a certain exaggerated sense of morbidity associated with it. And I think it's wise to dispel some of that. And that's the whole point of the next hour. Hopefully we'll convince you that these aren't this mysterious aneurysm that's forbidden, but something that needs to be kind of seriously considered when you encounter any one of these basilar aneurysms. So just for a little context, to prove to you that this isn't some esoteric aneurysm that really doesn't account for much of a practice, you can see here 454 basilar aneurysms. This is a year old even. And you know, that's a significant part of my practice. It ranges anywhere from 5 to 10% in most people's practices, at least in the older era. But you can see that it's not one to just give up on. You're going to see these over and over again. And I think it's important to learn to do these. I included this as one of the 7 in my 7 aneurysms. And so I strongly believe that that's one that we should work on. Now, it's beautiful anatomy. It's, as you can see, buried in this lattice of nerves and arteries. And you really, I think, have to be a master of the anatomy here. And also, you have to be able to be comfortable knowing what you can't see, because you only get little peeks of these things. I like the analogy of this being like going on a whale hunt. You never actually see the whale. You might see a fin, or you might see a tail, or you might see a spout, but you never really get a chance to see the entire beast. And I think that's so true of basilar aneurysms. You get these little glimpses of it. And it's really important that you have in your mind's eye this concept of the anatomy and the spaces that you're working in, and all of the surrounding booby traps that are awaiting you. So here's a little video just to kind of whet your appetite. Surgeon's view, positioned the way that we see it. You got to get to this space, and you've got to be really comfortable. Here with all the bony skull base obstacles, you can see how it's really buried in there. And so just a few brief comments on anatomy. It's obviously a bifurcation, or if you prefer to think of it as a quadrification, it's an end artery aneurysm. At the end of the basilar artery, the P1s are on both sides, and the PCOMs are obviously really important. Your classic anatomy is to your left. Your variant anatomy is to the right, with a fetal PCA in the center, and these hypoplastic PCOMs here as well. The hypoplastic PCOM is nice because it means that it's not an important artery. If you need to divide it and get it out of your way, it's done with impunity. If it's a fetal PCA, obviously you can't do that. So it's a mixed blessing. On the one hand, though, the fetal PCA means that the PCA is usually taken care of, and anything you do with the bifurcation around the aneurysm doesn't rely on preserving the P1 as much as it would if it were the classic anatomy. So, you know, it depends on how you look at it, but you just have to be aware of what you're dealing with. The name of the game for this aneurysm is the thalamoperforator. So I put these images just to remind you that they're typically asymmetric. One side often dominates the other, and there's this artery of Percheron where you can have a unilateral perforator trunk that contains basically all of the, or most of the major perforators. So you have to be particularly attuned to that anatomic variant. And I think this image here on the right, this Lawton picture, just shows you how densely packed these perforators can be in this posterior perforate substance here between the peduncles. It's not just one, it's not just a couple, it's a lot of these perforators. And if you lose any one of those, you can pay an extremely high price. So it's all about the perforators. Now, you're going to hear probably a little difference of approach between myself and Ali. I think you'll hear from him a bias towards the transcavernous approach for virtually all of these. For me, I use an orbitozygomatic approach for all of these, and I don't always go transcavernous. I choose this transcavernous when I feel like I have to have that additional exposure or need to get low into the posterior fossa compartment. I would say that the majority, though, can be done as subarachnoid dissection through an orbitozygomatic. And the reason I like the orbitozygomatic almost universally for these is that it gives you a lot of options. You can go in a more anterior trajectory over the orbit and get that high riding view, which is depicted here in this image here in the top right, where you drop into the orbital space. It gives you a view and a better perspective on the high riding basilar aneurysm. But you can also swing subtemporally here in this blue region if you need to come from the side, or you can go straight transsylvian, which is in between the two. And the orbitozygomatic gives you all of those options. no matter what trajectory you take, the Sylvian-Fisher split is absolutely essential. You can't expect to have the exposure and the room that you need without a very full Sylvian split. So I'm not going to go into the details of this. We've covered this in prior weeks, but you really do need that Sylvian split. And this is meant to show that the pathway to the basilar apex goes through 5 different cisterns: the Sylvian, the carotid, lamina terminalis to release CSF from the ventricular system, the crural cistern to free the medial temporal lobe, and then finally arriving at the interpeduncular. And I think the key in all this is these 2 arteries. Finding the PCOM, it's going to lead you back to the P1, P2 junction, and the enterocroidal artery, which is going to liberate that medial aspect of the temporal lobe. And if you just spend a little time dissecting these 2 arteries, you'll really open up your corridor. This is another favorite illustration of mine, just showing how, you know, the different steps involve the Sylvian split, which we've talked about. Number 2 here, there's often these arachnoidal adhesions under the temporal lobe on its basal surface. And it's good to free those up, because if you do a little pretemporal retraction and you don't, you can get some venous bleeding from that. Number 3 is the pretemporal dissection. There is almost always a temporal bridging vein, and unless you look for it, take care of it, it's going to be avulsed and bleed on you. So you've got to spend a little time freeing that up. And once you've done that, you can see here in number 4 how the temporal lobe starts to pull back, which is really important in opening up that pretemporal space. Number 5 is that anterior carotid artery dissection going along the uncus to free the medial temporal lobe. And lastly, number 6, always check your early temporal arteries, the anterior temporal artery or a pretemporal or temporal polar artery. These can sometimes tether the temporal lobe, and if you don't inspect for them and either dissect them free or occasionally divide them, you can end up avulsing them from the MCA and having a bleeding problem on your hands. So those are 6 very important steps in the kind of preliminary exposure. The triangles, there are many. There's the carotid optic in green, which is a very small space filled with perforators to the optic nerve and chiasm, difficult to work through, but certainly really nice to look through and gain perspective. The carotid oculomotor in blue is the main triangular space for the basilar apex. That's where, 9 times out of 10, you're going to do what you need to do for a basilar. The supracarotid in orange is occasionally useful for a very high riding aneurysm. And the interoptic really doesn't help you much. It's good to just maybe get some perspective, free some CSF. And a 5th triangle, which I didn't put in here, is oculomotor tentorial triangle back here, lateral to the 3rd nerve. That's what I call the bypass triangle. So if clipping doesn't work and you need to do some bypass, this is where you'll go. This is that oculomotor tentorial triangle here. And you can see S1, S2, and P2A are all right there, waiting to be serviced for whatever kind of revascularization you need. And important to remember that. Here are the steps. I'll just spend a minute on this because this is really important. Number 1, you can always find your way to the basilar apex because you've got a natural trail. Never a problem finding the internal carotid, leads you to PCOM. That takes you back to P1-2 junction. I like to go out to the tentorium here along the P2A segment just so that I mobilize the pretemporal space and the temporal lobe. Then returning back here to number 5, you go along the undersurface into the axilla of the P1. That'll take you to the S1 and the basilar trunk. So then all of a sudden, you've got your anatomy. Even if this is buried in thick subarachnoid blood and you have no idea where the aneurysm is, if you just follow these arterial landmarks, you'll have exactly what you need. Now, all of that stuff is really safe because you've not crossed the midline for any of that. So you're fully oriented before ever crossing the midline. And so when you do cross the midline, that's here in 9 and 10, I usually go from low to high, find the contralateral SCA, find the contralateral P1, and then work my way up to the aneurysm. Lastly, over in this corner here, you see 11 and 12. It's going across the neck and going behind the aneurysm across the back of the neck. And if you look really carefully here, the perforators are back in this space here. So number 12 is really the most important. And even further, if you look right where that X is, I call this the perforator of death, because if there's one spot that will get you into trouble more than any others, it's right here. It's that first perforator, contralateral side, closest to the aneurysm. It's the hardest to see because you're coming this way. And that's going to be where that perforator is either hiding or adherent or otherwise out of view. Couple variations to consider. Most of these are going to point superiorly, which is shown here. And because you're coming from a diagonal, here's where that perforator of death is going to hide, right here, that first P1 contralateral perforator, that's your blind spot. These ones here, the anteriorly projecting ones, I like these because these ones, the aneurysm tips away from the perforators, so the perforators tend to be safer. But if you think about how you're approaching this aneurysm, you're approaching the dome first. So if it's a ruptured aneurysm, these are the ones that are more likely than others to bleed. So you've got to be more fastidious about your proximal control. These here, the posteriorly projecting ones, I think are the ones most frequently talked about as the dangerous ones, because as you can see, when the aneurysm projects back, you can see all your anatomy. You see all 5 arteries around the quadrification, but the perforators get pushed down and they get difficult. They're in difficult places to see, so that makes them more at risk for occlusion. Now, 2 other variants to think about is the high rider. When the basilar is really pushed high, can sometimes get into the 3rd ventricle even, and you've got a blind spot here behind the carotid terminus, so you really have to get almost subtemporal, pretemporal, and look upwards. And for this one here, this is the low rider. This one falls below the dorsum, and this is going to require some clinodectomy work. So briefly, these are the clipping techniques for the superiorly projecting one. I really love the tandem clip. It allows you to break the neck into 2 discrete pieces, a distal and a proximal piece, and it also allows you some flexibility in transmitting perforators. The anterior projector is shown here. You can see how the perforators are away from the neck, so it facilitates the clipping. And so that's another favorable one, straight clip. The posterior projecting ones often require a fenestrated clip, either straight or angled. And you can see how the fenestration transmits the ipsilateral P1, allows you to work your way through this jungle of the perforators here and get it across the neck. So those are the basics. And now with the remaining time, I'm just going to show you cases because, you know, as we've done all through this series, it's the cases that are the most interesting. Here's a basic case, a little bit on the high riding side. You can see the neck was a little bit slanted. Here's the orbitozygomatic craniotomy. You can see the cuts here going across the zygomatic root. You can see it going here across the malar eminence, here across the orbital roof into the supraorbital fissure, and then finally across the lateral orbital wall. That removal of bone really opens the space up, so really incredibly valuable in terms of visualization. And then Sylvian fissure split takes us right down here. And now we're right into the heart of the case here. This fissure's been split. We've got our carotid kind of pushed to the side. And now I'm working my way pretemporally back to our aneurysm. So the 3rd nerve is coming into view here, and it's really important to free the 3rd nerve. I like to incise Lilliquist on the medial aspect. That helps the carotid oculomotor triangle open up. And you can see as you cut through all of the different Lilliquist layers here, you have a nice wide open view. The 3rd nerve kind of drops out of your way. You're seeing now the basilar trunk in your view here. And here's that beautiful pretemporal window that opens. I do frequently use a retractor. It's one of those cases where, you know, I rarely use a retractor in other circumstances, but to get that pretemporal window open, it's nice to just have a little hold on the temporal pole, and you can see how it opens the triangle. And now this is a pretty standard view. You can see not all that you want to see, but enough. You can see the basilar trunk. You can see P1 here. It's perforators on the back side. You can see the third nerve over here. Looking in the back for the perforators behind the aneurysm. These are coming into view now. And here I'm going to place a temporary clip. This softens the aneurysm, allows me to be a little bit more aggressive with my final dissection. And here now we have a view across the neck. You can see across to the contralateral P1. This is a fenestrated clip that's going on first in the standard tandem construct. And again, it's a very limited view. You're looking down a long shaft of an instrument. Your perspective is compromised, but you're looking to make sure that the very distal portion of the neck is closed, that the tip of the blade is getting all the way across. And that's really important. You don't have to focus on the whole neck. You just want to get that deep portion done. And then you can go on with any additional clips. This is icy green, showing good flow in our arteries. And yeah, actually that was just a single clip, a single straight clip on that one. All right, so that's a basic one. Let's look at this one. This one, as you can see, is more wide-necked. You can see it's standard position here above the dorsum sella here. And we'll skip this part and go straight to the dissection. So here, this is one where I decided to do an anteroclinodectomy to mobilize the third nerve. So I'm doing this extradurally, little fibrin glue to fill the cavernous sinus. And now, once that's done, I can do my dural flap and go trans-sylvian. And so just like the last case now, we're splitting the sylvian fissure, we're getting down on our anatomy. Here's the dissection down to carotid cistern and down into our space here. Now, this is an example of a very large bridging vein here. This is one of these dominant temporal veins, and this is one of the pitfalls of the trans-sylvian exposure. If you want to go pretemporal on this one, you either have to work around that vein or do what I'm going to show you in a second, which is a transposition of the vein. So here's the view. You can see now basilar trunk is here, the supracerebellar artery is over here. This is the third nerve being dissected here. Dana, can you? And so here's the PCOM here now coming in. And you can see that we got to start using some tricks here to get the views that we want. And the first trick that I'm going to use is this division of PCOM. And you can see when PCOM is divided, it liberates the carotid. The carotid just gets released upwards so that you can open up the triangle. Now, here I'm going to do my transposition of the sphenoparietal sinus. You can see I've gone into that epidural space. I'm cutting the dura, and I'm mobilizing the vein, bridging to the temporal pole with the dura so that it's a half extradural and half intradural exposure. And so you see now with the vein and the dura now freed, the temporal pole can be retracted. That opens up our triangular space here. And here's that carotid oculomotor window now, which is much wider than it was before. And now going back to the aneurysm, you can see how the aneurysm is in plain view. We can continue our dissection. Let me take the liberty of accelerating this. We have a temporary clip on there now. We can finish our dissection. The aneurysm is much softer. We can mobilize it out of the interpeduncular fossa. This, I believe, is a tandem clipping case. So you can see the first clip here is a fenestrated clip. The fenestration goes around a near portion of the proximal neck. And this is now just inspecting to make sure. Here now is the closing clip that's been applied to close the distal part of the neck. Here, closing where the fenestration is. So it's a 1-2 punch. It's a distal neck closure with the fenestrated clip and a proximal neck closure with the closing clip over the fenestration. And the combination gives us what we need. So here is a view of the P1 coming through that fenestration. It comes out of the trunk and over this way. Icy green confirms everything for us. Here's a little Doppler flow probe. And you can see, again, very tight spaces working through that carotid oculomotor space with the transposition. And this is just a demonstration of how that transposition gives you an additional centimeter of temporal lobe mobilization that wouldn't have otherwise been available to us. All right, so another case. This is a case we did just recently. You can see here, this is a web device that went into this aneurysm, and it compacted. So it was probably undersized and not doing its job here. The aneurysm recurred. This was a subarachnoid hemorrhage case, so not one to be ignored. But you can see the anatomy here. You can see, let me go back here. You can see the compaction here. And this is the treatment strategy we used for this. We did a balloon test occlusion here. And with her PCOM, she was able to tolerate this balloon test occlusion. So that made this into a very simple case. All we have to do for this one now is to do a Hunterian ligation. This is the Sylvian-Fisher split. You can see the carotid terminus, the A1 here. This is the M1 in the Sylvian-Fisher. And this dissection is going to carry us down. You can see it's a very small carotid oculomotor window here. We do have a little bit of retraction once again on the temporal lobe. There's the PCA coming up and over the third nerve. And if we follow our anatomy down, it'll take us right down to the basilar trunk. Here now, coming into view is the aneurysm. You can see right here, it's got this whitish wall. These are the two P1s as they come off of the basilar terminus. This is the contralateral one. This is now the basilar trunk. This is where we're going to place our Hunterian clip ligation. Our third nerve is in here, so we're medial to the third nerve, and this is our clip. So our job is done. I'm just looking at the aneurysm because I wanted to see if this aneurysm still looked threatening. But you can see what we're viewing here is that compacted web device at the dome, and it looks fairly solid. You can see more aneurysm back here. It didn't look very thin-walled or risky, so what we've essentially done here is a flow reversal with our Hunterian ligation, and you can see good preservation of perforators back here, and you can see the web device here through the wall of the aneurysm sac. So once again, there's our anatomy, small windows, incomplete views, but plenty to get the job done. Now, what do you do when you have trouble seeing? Well, these are some things: release CSF from the lamina terminalis. You can do some temporal lobe retraction. You can detether the pole by either freeing or sacrificing these early temporal arteries. You can divide the PCOM. You can do the posterior clinoidectomy, or you can do a transcavernous approach. So I think in the interest of time, I'm going to jump ahead to another video here that shows the transcavernous approach. You know, Ali is the master of this. I almost feel embarrassed showing you these things in his in his presence because he's the one who has championed this more than anyone. But I'll just show you this one case. It really has its value in two settings. One, getting low. So if you need to get low on the basilar trunk, as you can see from this blue arrow, it gets you further down into the posterior fossa compartment. And number two is just generally increasing the exposure. So here's a case example of where I think it's valuable. You can see this is a kid from Europe, had a subarachnoid hemorrhage at age 13. He was treated endovascularly with coils. His coils compacted and his aneurysm recurred. He was treated multiply with more coils for his recurrence. And in addition to that, he had a stent placed, but you can see recurrence again and again. So finally, he was referred for clipping. This is the surgical view, and I skipped the transcavernous part just to show you that when you do a transcavernous exposure, like in this case, it's not really to get low, it's really to widen the triangles. So that third nerve that defines the carotid oculomotor triangle can really sweep much further laterally. And so you can see that our triangle is really wide open. This is the view. You can see the basilar trunk right here with the stent in it. You can see the SCA, you can see the P1. This is the tentorial edge. Third nerve, we don't even see it because I've mobilized it so far laterally. But now with all that work done, it's time to attack this aneurysm. So I'm gonna isolate the aneurysm. This is a proximal basilar clip below the stent. You can see the tines of the stent through the wall. This is a temporary clip going on the on the distal P2, distal P1 segment. This is a clip now on the duplicated SCAs, ipsilaterally. And then contralaterally, this is a temporary clip on the SCA. So now this aneurysm is not fully, but near fully trapped. And I'm gonna actually open it up and get into it. So this is an incision in the fundus of the aneurysm. You can see with the CUSA, I can evacuate very quickly all of the soft thrombus that's around the coil mass. And you can see how this aneurysm sac is starting to decompress, to fold in on itself. It's important to remember that a coiled aneurysm is about 30% coils and about 70% clot. So you can really make significant inroads in softening this thing. And once that's done, you'll see we're going to again use our tandem clip construct. This is a fenestrated clip. The longest one that I have, it's a 12 millimeter straight with a 5 millimeter fenestration, and it gets about halfway across the neck. But you can see that with that incision into the aneurysm, we can go a little deeper now with the second clip. We go heel to toe, and this is enough to get to the back of the aneurysm. And now with some additional clips, we're going to close our arteriotomy in the fundus here with some straight stack clips. And that's going to close it back up again. And so now we've got the aneurysm debulked. We've got it reconstructed with clips. We've got good preservation of our SCA, our P1 over here. Ipsilateral, you can see the stent in there. And you can see our clip blades on top. Here's the icy green. We see good flow in the basilar. Here's the SCA. The PCA is so thick that it's hard to see the dye through it, but it's filling out distally. So all looks good. And now a little bit more thrombectomy here because he had so much mass effect on the midbrain. We can relieve some of that. And now our final inspection, you can see the perforators are preserved, the aneurysm is closed. And again, nice overview. Let me go back to this. Nice overview showing this very wide carotid oculomotor triangle. You can see how when you do your anteroclinodectomy, do your posterior clinoidectomy, mobilize the third nerve, it essentially gets out of your way and you increase that working space. So really valuable for that. Here's the before and after shots. You can see good clip reconstruction. The aneurysm's gone. And here he is before he headed back to Europe. Really a gratifying outcome. So I'm through my half an hour. I'm not going to show you bypass cases other than to say that You can do bypass cases. This is a P2 to SCA bypass side to side. This is another one, an M2 P2 bypass for a giant thrombotic basilar trunk. This one here is a thrombotic SCA aneurysm that we treated with a clip reconstruction plus an STA to SCA bypass. So a lot of different bypass options are available. It's important not to lose sight of those. Some concluding thoughts. I think it's safe to say, as we mentioned at the outset, that many, if not most, would consider endovascular therapy as the first line treatment for basilar aneurysms. But I think what Ali and I hope to convince you of is that there is a role for microsurgical clipping. Here's my short list of patients: the young ones where the durability is a factor, the ones with the wide neck where the recurrence risks are high and the efficacy of coil occlusion is low. Coil recurrences, like I showed you with that last case. The thrombotic and giants are notorious for recurrence after endovascular therapy. So I think in many of those cases, you're wasting your time with endovascular therapy. And then finally, if there's mass effect, fusiform morphology, then I think the clip reconstructive techniques are superior. So I would also, I've also thrown in the SCA aneurysm. The SCA aneurysm, I think, is one of those that's, even though it's a next door neighbor, it's a different beast. It's got fewer perforators, better visibility, better outcomes. I think that's one that should definitely remain in the open surgical wheelhouse. And all the approaches, all the techniques that I've talked about here apply to that one. So last point, there's so many tricks. I've shown you just a handful, but there's so many tricks here, from the interclinoidectomy and mobilization of the third nerve, to the posteroclinoidectomy, to the division of the PCOM, to the transposition of the pretemporal veins. I mean, there's just a long laundry list of tricks that you just may need. And it's hard to always predict from pre-op films what you're going to need. You just have to have these in your armamentarium ready to deploy. And I tend to start with the standard approach, the standard Trans-Sylvian, and then I escalate as these challenges are encountered. And as you can see, you can build on the mix of tricks depending upon what aneurysm you're faced with. And that's generally my approach. So let me exit and let me stop the share.
Great, thank you, Michael. Well said.
There we go. All right, it's all yours, Ali.
All right.
You pick, there you go.
All right.
Okay, perfect.
Again, thank you, Michael. Well said. And Michael addressed all the points that, like he said, he and I share an opinion about handling those aneurysms. And I want to start with this. These are the messages that I get on my email. They're so frequent. And if you notice, the subject is, and it's kind of came very fitting that Michael finished with this horrible case that he showed. And that's what I get. This is one of my colleagues in Europe also. It says, another horrible coil case. And he sends me this case that has recurred and recurred, and the patient is not doing well because, as you noticed on the scans that Michael showed, this becomes a mass in the brainstem. Now, we do know that microsurgery is superior to endovascular therapy. And this is a meta-analysis of treatment of basilar apex aneurysm, and it says that complete occlusion is achievable in 93%. and lowest rates of rehemorrhage and retreatment. So we know that the end result is better. But as Michael said, there is this morbid fear from even thinking about surgery when it comes to basilar aneurysm. And I think this comes from lack of knowledge. It's pure ignorance. You know, fear comes from the unknown. And if you're not knowing something, that you're going to be afraid. And this psychological fear has been transmitted through a lot of our educators, to where there are some, you know, trainings where residents have never seen a basilar aneurysm or any surgery done there. Now, I want to go back to some of the principles that we mentioned earlier. Aneurysm surgery should not be brain surgery. It's subarachnoid surgery, and basilar aneurysm exemplify this concept. And the other thing is, clipping aneurysm is not a step, it's a process. It has many things that evolves to it. As Michael mentioned, there is many steps that you have to put together and pick and choose to where you can achieve the goal that you want to achieve. Now, when it comes to aneurysms, this is another example. It's really not fair for a 35-year-old to end up having a more of a difficult, morbid state case with a third nerve palsy and other, you know, deficits related to compression of the brainstem, when they, in a case like this, they could have been cured. I don't know. I don't know what happened.
Just keep trying.
Try to share
Okay.
again.
Do you want to start your PowerPoint again, or are you looking to start the video?
No, one second. I
Okay.
should be able to share with you again.
Oh, okay.
Okay. Can you see me now?
Yes. Mhm.
So,
Perfect.
yeah, and if you look at this aneurysm originally, it's really not a complex case to treat. And it's unfortunate that this young patient ended up with such morbidity. At the same time, when I received those emails, I had a case like this same age in her, like around 40 years old. This is a case which was treated with what I call the one variant of the transcavernous approach. Now, why do I use the transcavernous approach? And I'll make some points. If you look at Drake's comments when he was talking about the subtemporal approach, he actually said the best approach is one that combines the subtemporal and the pretemporal and the transsylvian approach. He puts them all together. And this goes even one more step. It gives you more ability to mobilize structures that will open those spaces which Michael mentioned. I think the oculomotor carotid triangle or space is really the most wide space, and the space that can be widest, you know, in terms of the ability to maneuver around. The other thing is, just like he showed in the last case, the ability to maneuver around increases significantly. So that gives you an advantage. Now, if you're very experienced, you've done several hundred to 1,000 cases, you may get around the corners and be able to see more with your brain. But when you're starting, you really want as much space as possible. And that this approach achieves it. And unlike what some describe it as complex, invasive, and all this stuff, you're as invasive as your surgery and as your hands. There is nothing invasive in what we do. Once you make an incision, that's it. You have already invaded. So those concepts have to be taken out. Our surgery is delicate. It's not invasive. And when we tailor our approach, it is tailored to one thing. It is safety, a good outcome. The idea, take less bone, take more bone, and all these nonsense that are discussed, they don't mean anything. So, Michael mentioned he likes the orbitozygomatic approach. And if you like the subtemporal approach, if someone likes the subtemporal approach and you feel comfortable, it gives you the strength and the power and the control, do it. So whatever you do is, it has to be what makes you most comfortable and most confident. Beyond that, you can add to it. And those are my points. In my case, I like as much preparedness when I get to the aneurysm, because I don't like surprises and I am not sure about the anatomy. There are variations in the normal anatomy. Some patients have very narrow spaces between the oculomotor and the third and so forth, and you may not be able to achieve what you want in highest level of safety, and that's why I use it. So my approach is really a modification of the pterional approach. The difference is I go more towards the zygoma. I can remove the zygoma if need be. Usually if a patient has very large muscle and I have to look up to a very high riding bifurcation, then there's benefit to go lower. Because my approach is more lateral and pretemporal and subtemporal, I am combining all these together with the Sylvian Fisher opening, then I haven't seen, in my cases, the need to remove the orbital rim, but I do shave it down with the sphenoid wing flat with the orbital roof. Now, once the opening is done, you can see how much temporal lobe is exposed versus the frontal lobe as well. And then once the craniotomy is performed, the real money is in achieving the wide exposure at the depth. So a lot of times you can have a wide exposure on the outside and you can add to the deep part, but with this approach, you're widening the deep part significantly to where all this space becomes available to you, irrespective of the location of the aneurysm. So in this case, if you look at it, this is the third nerve that has been skeletonized. And one of the reasons I like to do this is because it improves the recovery of the third nerve. The third nerve intradural component is the most vulnerable to injury. And once you release it, then it becomes less likely to be permanently injured. I use the example of a string of a guitar. When it is tight, it makes music. Music is injury. When you release it, it is more kind of undulating, then you get more recovery. The other thing is, and you can add, or depends, in some cases I don't remove the posterior clinoid process when they're very high because the basilar can be reached, but not in every case I remove it. The anterior clinoid I remove because it really creates a space and allows me to mobilize the third nerve. In this case, as Michael mentioned, this was described by Yazergil, and he is right. We published our experience with it. If you coagulate at the perforator-free zone, you're not going to get into problems as long as this is hypoplastic or smaller than P1. Once you get this exposure, if you look here, there is a clip on the basilar, clip on the opposite side, and look how much space, and you can gently take the third nerve, which is bent and not injured, and now you have a full exposure, so that surgically what you're looking at is this kind of a view. This has a posterior bulge. You can look behind the aneurysm, anterior to it. So these are the clips that you've seen in the picture. And now you can see all the perforators after collapsing the aneurysm. And then clipping it is even easier than some other anterior choroidal aneurysm or an ACOM aneurysm. So unfortunately, a lot of the easier aneurysms are being coiled, that we can very simply clip them, and we are left with the more higher complexity cases. So again, you can see the view here. This is a cottonoid behind the perforators. You see 360 degrees around it, and there is nothing that you have to worry about. And at the time you go home, you make sure that you didn't leave anything behind. And this is the outcome, as compared to that 35-year-old who now have an ongoing chronic problem that is very morbid, like in this case that I showed. And the examples are many. This is from my clinic and from referrals. It's really devastating to a lot of these patients, what you see. This is a orthopedic surgeon from Taiwan, and the end result is a locked-in syndrome. He got complete strokes, another case, strokes in the brainstem, and this is really has to change. So when is surgery a superior option? Like a lot of the surgeries we do, when it is done at a superior level, quoting the late professor now, De Oliveira, one of my mentors. And this is a slide which Michael addressed. Basilar have a lot of problems that makes them come back. You know, hemodynamic stress location, mass effect, neck wide, when they are giant. All these are examples that need to be addressed, other than young age and the fact that this is more durable. And that's how you can achieve results like this, or like this, like this, like this, and so on. And now, this is to give you some examples, starting from lower complexity to higher complexity, and the different aspects of achieving the goal. So this is a case which has a posterior bulge, but mostly superiorly projecting. So we'll take you through the steps. And this is a pretemporal, a wide exposure in a way, or down to the subtemporal region. So it's really combining the pretemporal and subtemporal together. Then I remove the posterior third of the roof of the orbit, and then we open the meningioorbital band. And then this is my beginning of the dissection for the lateral wall of the cavernous sinus. This is the picture I like to see, because this is that allows the window to get to the basilar region. And once this is established, then we go to our opening, and then, like Michael said, in the overall majority of cases, you have to open the sylvian fissure. Occasionally, very low basilar trunk or behind the clivus, you don't have to. And the opening of the fissure is as described by Yazergil. We went over this before, so you can see all the steps in it. But the approach shows how we go through this is skeletonizing of the third nerve. And now you can see the window starting to widen significantly, and the basilar artery is seen. Then we take PCOM so we can look behind the aneurysm. And then this is the view you start getting. And you see how much space you get, and the maneuverability is unhindered completely. And that's the space you get. So now you can see a perforator-free zone in this region that we're gonna put our clip. You can see the two perforators. You have a wide, nice space. And once we get that, we swing the microscope up. You put another one on the opposite P1. And now you have full control of your hemodynamic aspects of this aneurysm. It's collapsible. And then you start applying your clips. And in this case, it was relatively easy type of putting the clip. You have to, this is the aneurysm being collapsed, looking around it to see all the perforators, so that by the time we finish, the view you see, it is really, there is no blind spots in your way. So we'll take to a higher complexity cases. That's the view you can see. As Michael said, it's a very nice wide space that you achieve your exposure in it. And the closure is all done subtemporal and reconstructed just like any other case. Now, this is a ruptured case, and as you can tell, this is, is going to fail endovascular therapy. It has a wide base, kind of distorted, multilobular. And once we get the approach, and we will go quickly through this, and then you will see the time you expose, this is the view you get. This is third nerve. This is the carotid, the posterior cerebral artery. The opposite side I can see because I removed the posterior clinoid. And now the aneurysm is visualized. We've already cut PCOM in this case. So now the clip is applied to the basilar trunk. And when you look around, you can see fully around it. You can see now there is a large perforator which is attached to the aneurysm, but we can get into this space, and this is the first clip. The first clip, we call it the pilot clip, and that's the clip that would allow you to see and then put a better clip. So we will collapse the aneurysm, and then you can look around. Now you have a better, safer view. There is a cotinoid on the other side already. This is a safer clip than the first one. You take the first one, now you have an unruptured, smaller aneurysm. The rest of it is dissecting and perfecting the clipping. And you can see the perforator here attached to the dome, and that's the other side, perforator pushed by a piece of cotton. And you have, again, no blind spots. You can see temporary clips applied. They're not in the way when you are applying the clip. So the space is really majestic to what you can get and achieve. And that's the perforator, and this is the aneurysm completely clipped. So, and this is the view of it when you finish. You can see both sides, behind it, in front of it. You can see the whole complex. And look how much space we have created. Now, another more complex, posteriorly projecting, like Michael showed, these perforators are usually more on the superior part, and the approach is the same. I'll go fast through it. And then once we get down to where the aneurysm is, then we're putting a clip on the basilar. This is a clip on PCOM. On the ipsilateral side, it was a large fetal PCOM. And you can see how this is P1 and the basilar. And now this is basilar, P1 coming above the third nerve, and the opposite P1 on the other side. And now you're looking around and dissecting the neck of the aneurysm. There is a cotinoid that was pushed. And I put the clips on and off, and then you just dissect until you build a 3D picture in your mind where the clips, the clip blades are going to go, because then the clip blades will have eyes. Like you see here, the cotinoid pushed the perforators are above it, and then it becomes very secure to put your clip in a way. So I'll go faster to show other cases. Now, they get bigger and more posteriorly bulging. They become more challenging, as you can see. And the same thing applies to them, that you don't feel like you are squeezed because you can see the same space. This is a clip on the opposite P1 we've already put on the basilar, and that's, you see how much space you get, and that's even on the ipsilateral P2 because it didn't collapse as much. And now you can see this is a posterior bulge and a superior bulge. And in this case, you just take your time. Sometimes I put the clip, and then I use bipolar cautery when it's feasible. And then you can see here the perforator that Michael talked about on the opposite side. And by collapsing it, you can see very nice the space where your clip is going to go. So in your brain, you already have a roadmap that is safe and has increased amount of safety to where your clip is going to go. And now the rest of it is going to be, an exercise of anatomy in a way. So that's the first clip. I'm applying it. In this case, I'm using the bayoneted clip. I like it because it kind of gets out of the way when you're putting your clip and visualizing both anterior and posterior. And now the next step is to look quickly to see if anything major you caught, because you have some time with the temporary clips. And the second clip is the safe clip, because now you are clipping a smaller aneurysm and a narrower aneurysm. And I am pushing the perforator here. You can see this is the perforator here, and the clip is going below it. So the second clip is more, kind of has better eyes in a way. And once we secure it, you see the opposite side, and this is the space. Then the first clip tends to be always coming down on the bifurcation. And once we get this out of the way, so now you can see the anatomy better, and then we will collapse the aneurysm so we can. Now, notice how careful I was removing the clip. And please, when you're operating, do not underestimate removing the clip. And one of the most common times I've seen residents and fellow rupture an aneurysm is removing a clip. So you have to do it very carefully. So this is, again, the aneurysm collapse, and you can see the space behind it. And the rest of it is making sure I don't go home before I, that I didn't catch anything behind it. And that's the space you can achieve. So again, it's all about exposure. There's a little residual dog ear on the bottom part. We're going to put a clip on it. And once you get the right exposure, good control of hemodynamics, then you can use all your tricks to finish the clipping. So even bigger, this is a, sorry, let me show you the. So this is even bigger, posteriorly projecting. But again, what you need to see, and Michael mentioned that, is the neck. I don't care about how big the aneurysm is. I care about the neck. I want to see it. I want to make sure that I can clip it. To me, this is clippable, then that's where the money is. Now, again, to save time, I'll show you how the exposure leads to the opening. This is the basilar and the third nerve, and you can see the space widely open. This is superior cerebellar. This is the posterior cerebral. This is the opposite P1, ipsilateral P1. And once we get the temporary clips applied, the aneurysm becomes manageable to collapsible and so forth. In these cases, when they are posteriorly projecting, you have to account for those perforators that sometimes coming either on the side or sometimes overriding anterior to it, like you can see here and this one. Now, those have to be, you cannot try to clip them once and for all. You have to collapse them before. The way I do it is I compress the aneurysm and then put first clip on the bifurcation itself to make the whole neck. You see here, it's passing this P1, but going on the opposite side so that this becomes more collapsible in a way. There are different ways of doing it. You saw Michael likes to put the fenestrated clip and then put another one to close the fenestration. But the point is, there are many ways of achieving this goal, but you need good visualization and the ability to maneuver. So that's my second clip. I'm putting it to compress the whole apex. This will make the aneurysm a smaller collapsible aneurysm. And then you see now the aneurysm is smaller. And I look on the opposite side, and now I know where this clip is going to go. And I've already made the aneurysm narrower, which is from here to here. So I'm passing the perforator, and now I'm going to the opposite side. So what we really did here is I put one or two clips to collapse this part. Even if I include P1, that made this smaller. Then I slip a clip in and take this one out, and then you can finish the job. But to do that, you need space, you need maneuverability. By the time we finish, this is how the view looks, and you can see the aneurysm and everything clipped. This is a low aneurysm. This is another version of it. When they're very low like this, you need to do a more exposure. In my case, I enjoy doing the full transcavernous approach. This is an exercise of anatomy. So we mobilize the fourth nerve, we open Meckel's cave, and this is the fourth nerve being mobilized because all this space give you access. So you find carotid, sixth nerve. Why? Because you want to be posterior and medial to those structures, then you are safe. Now you're looking at the space you're creating. This is the petroclival dura. We removed part of the bone with the bony cusa, or the sonopet, we call it. And now the clipping of the aneurysm becomes the easy part in a way, because you have full exposure. Now, fourth and third nerve are above me, and I am way down behind the clivus. So I can safely clip. You can see my clips going around it. I put a piece of cotton behind the aneurysm, and I have full view of my blades. And you see the blades here. I can see my blades very nicely, and everything is protected. It's all in space. So when we finish clipping, that's the view you get. Take the clips out and collapse the aneurysm. You can see a little perforator here on, and then take the cotton and we do our ICG. You can see all the perforator, the clip, and everything free. Take it another level. This is a very large, complex aneurysm. This is destined to fail, but to make it worse, look at the location. It is way down. That's a great approach. This was an acute ruptured aneurysm, a great one to do the full transcavernous approach. So we are opening, that's the carotid, V1, fourth nerve, third nerve, and then this posterior, the petroclival ligament, then you stay posterior to it and medial. Mobilize the fourth nerve, and I'll speed it up some. This is the fourth and third being mobilized. So all this space now is going to be available for us to unlock. So once we do that, this is the Meckel's cave being opened because it's part of the tentorial opening. And now you can see the space that we are creating. Once we take this piece of dura, because this is a dead piece of dura, then look at the window we get. So gradually our aneurysm now is going to show up. That's the aneurysm. This is PCOM being removed. And now we have, this is PCOM, and gradually that's the aneurysm comes into view. And then once we get, in this case, look why I'm doing that, because I am removing it so I can see the opposite P1. Imagine how much space. I will not attack the aneurysm until I get full control of the hemodynamics. Now I'm putting a basilar trunk, and then now the clipping is much more visualized, and I can see very well. And that's kind of how the anatomy looks when you're doing all these. These are the perforators behind it. You can see very well in 360 degrees. In this case, this patient was clipped, but there was a little residual. There is a small residual that you will see in a second. And I will make sure that I perfect the clipping. So once we take the clip, we look around, and this is the residual which was left. And when we lift the aneurysm and move it forward, that's the residual here that you see it. So then we will take another clip, which is a curved clip that will go on the residual. Sorry. I'll move it to the end. So this clip goes underneath, and then the whole complex will be reconstructed without leaving any. So even if it is quite large and as complex as it looks, we will be able to achieve full and anatomic, and that's the space you get, and that's the post-op. You can see the angiogram. The last to show is kind of to show you how easy a complex case can become with the right exposure. This patient has an aneurysm which was at the basilar trunk and has a fenestration and could not be treated otherwise. And there is even a clip on the posterior part in this case. There was two aneurysms, one which was not really visualized well. Again, in this case, we did the full transcavernous approach. And then these are the steps, mobilizing the fourth. This is the carotid, sixth nerve, and now finding the fourth that you can see here. And then we skeletonize the fourth. And then mobilize it out of his gutter. Once you move it, you take it medially, and then all the space will open up. Now we mobilize the third nerve. You see the fourth and third now are mobilized. So all the space now is ready for you to be utilizing it. Open the Gasserian ganglion, and now the dura medial to it is all safe to remove. You will see in a second this complex aneurysm that is looked at as very difficult and so forth. It's the most ridiculous aneurysm to clip. Why? Because we achieved the right exposure. You will see in a second where we are. That's all the space we created, and the aneurysm is hiding in this arachnoid. You see that? Look how ridiculous it is to clip the aneurysm. It's just waiting. And what made this is the approach. It's the opening. And now the clipping part is the easy part. And then we look behind it, you can see.
Dá licença. Eu tô assistindo.
So that's the clipping. It's really, again, many aneurysms are like this. Paraclinoid are examples, like I mentioned before. They are easiest to clip, but once you achieve the exposure. Aneurysm surgery is about exposure. It's all in the subarachnoid space. And in this case, there was an aneurysm behind it. You will see it now. And that's the aneurysm you can see that was not visualized before. See that? And this is all clipped. And again, the window after we finish is magnificent. So I'm going to stop here. This is a case just to give you an example. Sometimes we can be more creative if we're operating. If the perforator is around it, we could not avoid it, except if we put a clip away from it. And anyway, what we ended up doing, and I'll show you in a second, in this case is we did a combination of, we clipped the aneurysm, and then there was a small residual we had to leave open through the fenestrations because the fenestration was around the perforator, and we ended up just putting a couple of coils in the surgery, in the operating room. So in posterior circulation aneurysm, we have experienced about more than 300, but this was an old slide. It's close to 190 aneurysm that I've used, the pretemporal approach or one of its variants. It's important to say that because everybody, when they comment about our work or my work, they mention you don't have to do everything at the same time. I don't do everything at the same time. I tailor it based on the need for those cases. What's important is the recovery in the oculomotor nerve is, and we published this, is more than 98%. And the outcomes, even in ruptured aneurysm, these patients do better than others because the bleeding is not affecting the brain directly. It's all in the subarachnoid space. 80% of patients in 1 year are doing very good in spite of high patients with high Hunt and Hess grade, and more than 98% of the unruptured aneurysm are in full recovery. So it is really wrong to exclude this option for patients. And I think we're doing a lot of patients, a disfavor or unfavor for them for letting them go with a choice that keeps failing. And even with the most advanced things, I know the people get excited. A lot of my friends and colleagues, every time there is a new gadget in the market, but we have to kind of adjust our thinking. Just put yourself in place of the patient. None of them wants anything less than a cure. And the idea that people are afraid to have their head cracked open, I think this is ridiculous, because I have never, if you're a comfortable surgeon, you're going to make your patient comfortable. So I'll stop here, and I think we'll see if Dr. Aboud about some questions for.
Well, thank you very much. I think you both made it clear, so there is no questions. I don't see any relevant question. But maybe I suggest if you have both few words to young neurosurgeons who might start approaching basilar tip aneurysm, what are the advice, and what do you advise them?
Michael?
Yeah, I'll say a few words, then I'm going to have to sign off because I got a meeting to go to. But I will say this. It's hard for the young neurosurgeons to take these aneurysms because I think they're heavily scrutinized. I think there's a lot of criticism if one takes these on and is perceived as being perhaps over-aggressive or not recognizing the endovascular options. So I do think it does take some bravery, some courage to take these on. I can only say that you need to do that if you're ever going to hope to become proficient in this. You've got to just commit yourself to doing a certain small number of these. The ones that we've talked about, I think there's agreement on my part and on Ali's part on the ones that are appropriate for open surgery. And I think if you make those decisions and those selections wisely, you can justify your work. And you just need to make that commitment to do it. I think there is the potential for some flack or criticism, and I think you just have to stand firm.
So, yeah, I agree. I agree with exactly what Michael said. I would say nothing is impossible, and you have to know your limits, like he said, but have no limits. And you have to keep in mind those approaches that we use are not only for aneurysms. I mean, these are used for a whole spectrum of pathologies. So if you're going to be a microsurgeon, you decided to do microsurgery in the brain, you're going to be equipped to do all this. A tumor surgeon should be a vascular surgeon, should be able to handle blood vessels if something goes wrong, wherever it's located. And you know, Dr. De Oliveira, you know, I would like to quote him about what it takes to dedicate yourself. You have to have the passion, you have to stay the course and be determined. As Michael said, you have certain courage to do things because you are going to be in a place. And even myself, over the years, I decided to block the criticism because I knew this was best for my patients when a lot of people saying what I'm doing is too much. And each one of you have an inner sense of whether you can achieve this, and do not hesitate. Do not think about, you know, what other people are going to say about you. You have to think about what's best for your patient and your outcomes, and think about your performance and preparedness. It's all in you, it's not outside. And that's what counts. So anybody can do it if you put the right effort and the determination to achieve it. It's those who criticize you and want to stop you, the reason they want to stop you is because they didn't they're not able to do it. As simple as that.
So, which patients are evaluated for familial aneurysms, and what is the scope of this molecular genetic evaluations in aneurysm? And can immunomodulation or immunotherapy help in the natural course and treatment of such aneurysms?
If I understood your question,
I put in the chat box.
Huh?
Do you have camera, Uday? Maybe we can understand you if you see your face.
Yeah, just hold on, sir.
Here, let me get it off the screen.
Now there's another question, Dr. Krisht, about the time of temporary clipping of the basilar trunk. How far can we go?
Well, you may get different answers from different people who have done basilar aneurysm. If you may hear Michael gives one opinion and Dr. Ernest-Nemi, who has a lot of experience, gives an opinion. I may give up, but they are all similar. There may be a difference. You may hear from somebody 2 minutes, 3 minutes, 5 minutes, but they're all the same. What it is there is a certain amount of safety. If you stay with below 2 to 3 minutes, the likelihood that you will cause a problem is extremely low. You can repeat this many times. In the basilar area, unlike other areas where you don't want to stay for too long, there is not maybe enough collaterals in some patients, especially for the perforators. Now, when I put my clip, I put it below the superior cerebellar. The reason is the pica, posterior inferior cerebellar artery, brings blood through the collaterals of the superior cerebellar artery to the perforators. So it gives you more time and more safety. That's on one hand. The other thing is I look at the aneurysm and I gauge it. If the aneurysm is completely collapsed, then that means the patient doesn't have collaterals. That means I have to act fast. So, but the advantage of it, if it's completely collapsed, I'll put my clip and look around. And if it's completely collapsed, it allows me to see and then to act quickly and finish the job faster, or put at least my pilot clip to secure the aneurysm. If the aneurysm is still filling but softer, then I know blood is coming to the brain and I have more time. I can use my 2 to 3 minutes. I usually tell the nurses to tell me when it's 2 minutes. And if I feel like I am almost there, I will continue for another minute. I do use intraoperative monitoring with somatosense evoked potentials and brainstem evoked responses. And if there is any change, it will also affect my decision-making process. Now, the other thing is when you do the clipping, when you commit to put your clip, you want to be prepared. So before that point, you can put the temporary clips, dissect gently, and then take them off, put them again, take them off. Sometimes I've done it 10, 12 times and in a very complex aneurysm, and each time less than 2 minutes. And that will not be harmful at all. It's zero effect because you're reestablishing flow within a short period of time. It is when you keep the clips for too long is when the problem. So for you to act fast, you have to have known what you're dealing with. So you know where your clip is going to go and what your plan and how you're going to approach and where the perforators, and this will cut down the time when you commit to the clipping. Prior to that, if you're not ready and you put your temporary clip and you get in there and you want to clip and you find it difficult, you're surprised, something bleeds and so on, and you don't know still the whole anatomy in 3D, then you're gonna be in a very tricky situation. So that's how I approach it. The temporary clips are to enhance my steps and give me more knowledge around the aneurysm and to make my clipping more safe in a way. So it's a dynamic process. There is no, it's not a fixed picture that you want to do every time.
Okay,
You have to read the pathology. You're looking at it and it's talking to you all the time.
Okay. So go ahead, Uday.
Go ahead, Uday. Go ahead, Uday.
Parsathias, Dr. Data, unmute yourself and ask your question.
So, which patients and families are evaluated for familial aneurysm, and what is the scope of molecular genetic evaluations of these ruptured and unruptured aneurysms? So, can this immunomodulation help in the treatment of such patients?
I didn't understand your first question, but I understood the second one. What was the first question you asked?
So, which families or like patients in who presents with centennial headache, or which families or which patients are evaluated for familial aneurysms, like if they come in the OPD, and what is the scope of the genetic evaluation of such patients? Is the genetic?
So if the first question is it about familial aneurysms?
It's a random patients come to the OPD, and how which patients will you'll retrospectively evaluate their families for the score for the aneurysm.
Yeah, well, usually if there is already an established rich family history, then I will look at it in a different way, and I'll have even a low threshold to treat those patients, because I think in my experience they're more prone to have problems than the others. They're patients with familial aneurysms have active aneurysms. So that brings us to the second question. Actually, in my discussions with Professor Yazegil over the years, he's always said, there are active aneurysms and inactive aneurysms. Are we able to know the difference now? There are some suggestions, there are some studies, if you look at the literature, which looks at MRI changes in the wall of the aneurysm that suggest if there is inflammatory process, that there may be some more predisposition to bleed. But a lot of these have been done also in retrospectively, not prospectively. Some studies have been done also by cutting part of the aneurysm and studying it and finding out that there is certain complement fixation problems and things like that, which are the aneurysm is already immunomodulated. There is no doubt when we get in there, we see changes. Yesterday, we did a carotid bifurcation aneurysm. The patient has history of headaches, but not recently. When we got in there, we found old blood. So, and the aneurysm has multiple little heads. So it tells you that this was an active aneurysm, even though when you look at it preoperatively, based on the natural history of unruptured aneurysm studies, you shouldn't be operating on it, that case. So now, my decision with aneurysms, I have a low threshold of treating them. To me, treating them is safe, and the price is so big when something happens. And we still at the stage, we have no way to 100% tell a patient, go home, be okay, nothing is going to go wrong. And it's interesting what you notice, if the surgeon is uncomfortable with surgery, they tend to kind of believe the studies that says, these are safe, don't operate on them. And if the surgeon is comfortable and experienced, you have seen all sorts of things. And when a patient asked me in the clinic, do you think my aneurysm will bleed because my neurologist told me that it is anterior circulation and it's not going to bleed because it's about 4 millimeters and it's an anterior communicating artery aneurysm. What do I tell him when the day before I treated a ruptured aneurysm, which was 4 millimeter and anterior communicating artery? You know, our experience dictates, you know, our perception of the risk. And the other thing is, a ruptured aneurysm is not a minor thing. You know, it's not a headache. You have to keep in mind 50% of patients either die or they're severely morbid. So this is not like falling from standing position. This is like crashing from a plane, you know, or in a car. So it's not a minor event. So to me, it's if you can treat it before it causes problems, and you can treat it with a low mortality and morbidity, which beats the odds of the natural history, which we can as surgeons, and we've published this. You can look at our study. I looked at the natural history studies, and I took my patients and included them in the natural history studies, and compared my results of surgery, compared that if we didn't operate on them, we found out that much less patients will die if you operate. And so if you're a competent surgeon, I can tell you your results are going to beat the natural history.
This fluid dynamics, are you evaluating fluid dynamics, computational fluid dynamics in the aneurysm treatment, like in Basilar also?
I don't. I am not doing it. I am aware of the literature. I look at it, and there is a lot of factors which may not be applicable, but at the same time, you know, there are things which are clear. For example, as if you're familiar with it, when aneurysms are a little bit off the center, more on P1 or another P1, like some of the cases I've shown, they're more prone to bleed than others. But you have to keep in mind, basilar aneurysms is a hemodynamic disadvantage point. So that's why the basilar aneurysm and carotid bifurcation aneurysm and other aneurysms, like some PCOMs and some ACOMs, when you have one ACOM and you have a dominant A1 and two A2s coming out, if you look at it, sometimes it looks like a basilar bifurcation. So, and you see them because they bleed, you know, so.
Another question from Nicholas. He is asking, do you release the full cavernous course of the fourth nerve when you dissect it?
No, the fourth nerve is never, I usually stay epidural and in the middle fossa, and I never dissect it unless I'm doing a full transcavernous approach. If I'm not, which is in the overall majority of cases, I mobilize the third nerve, but not the fourth nerve. Now you have to be careful with the anatomy of the fourth nerve when you're doing this approach, because sometimes it comes close to the tentorial edge in your way. But usually I don't deal with it, except for like the couple of cases at the end that I showed you when they're very low.
Okay, maybe the last question from Dr. Data. Unmute yourself, sir.
Yeah, thank you, sir. Then the modalities like which soften the aneurysm, like hypothermia, then rapid ventricular spacing, adenosine, as you have already mentioned, that basilar top aneurysm is hemodynamically in a very difficult position. So do you think that apart from wide exposure and putting temporary clips at the strategic points, the mechanism to soften the aneurysms also brings some good result?
Okay. Yes, it can. I'm not sure about hypothermia, but I know, I don't know if you meant hypotension, or using adenosine to stop the flow. I have not used it myself. I've prepared a couple of times. I ended up diverting it. But there is a certain unpredictability in the response when you use medication, and it's very short-lived based on not my experience, but based on when I talk to other colleagues like Professor Hannesnami. You have like 20, 30 seconds where you have to do this. With the temporary clips, you have 2 minutes and you have more time. Plus, it is not only about the softening. The softening, and you need more space so you can have more maneuverability and you can do things faster. And I'll give you an example. Imagine if I put you in a small telephone booth and I tell you, I want you to change your clothes, okay? It's gonna be difficult because you're trying to move in a small, narrow space. If I put you in a big room and I say, change your clothes, you'll finish it fast. And that cuts down on your temporary clip and increases your maneuverability and your safety. When you're in the telephone booth, you're gonna hit your elbow 3 or 4 times and your head and your legs and so forth. When you're in a big room, you have space, nothing's gonna happen. So do not be scared to achieve more space. There is a trend to make a smaller window, and my window is not big, but you have to widen the window at the depth. And there is a trend to do other things, but you are doing 2 things. You're gonna end up meeting very difficult anatomy in some patients. And then what do? If you go in there, I can tell you, I'll give you one example. We all know that there are some patients who have a small epidural hematoma and they herniate. Another patient will have a large epidural hematoma and they're still okay. Why? Because the anatomy are different. One patient has a small incisura, one have a big incisura. The same thing you're going to encounter in surgery. Some patients have a small incisura, a small space. The nerves and artery and everything is kissing each other. Carotid is kissing the third nerve, kissing the optic nerve. There's no space. So what do you do then? You're stuck. You know, I like to use the example. When you go to war, you don't take one bullet. You know, you take many bullets. You take a machine gun, you take a piston, you take a knife, you take a bazooka, you take whatever, and you use whatever you need. You have to keep in mind, there is a patient who committed to you for success. So you need to commit for a story of success.
Sir, another question. Sometimes, even after putting the temporary clips, one surgeon may not be sure that whether he has totally occluded the flow to the aneurysm. You have put a temporary clip on P1, you have on the contralateral P1, you have put another clip, on the basilar trunk, you have put another clip. But even after that, sometimes the target of the aneurysm is not so soft, and you are not 100% confident that you have totally occluded the flow to the aneurysm. So do you think that a microvascular Doppler gives you some advantage in that situation?
If you put a basilar trunk clip and you put on both P1s, there is no reason that you should not have a softer aneurysm. If that's the case, then something went wrong. Either one of the clips is not catching the whole artery, or your P1 maybe clip is beyond the PCOM and there's a big PCOM on the opposite side, but usually it's not that possible. And for collateral flow from the superior cerebellar to be so strong to not allow the aneurysm to collapse, I have never seen it. It will be strong and the aneurysm will have turgor, but it's collapsible. So when you're putting the clip and closing it, it is deflating as you go. So
do you use this microvascular Doppler in your surgery?
Yeah, I use it all the time. It's helpful.
All the time?
Oh, yeah. Yeah, it's available. I rarely use it to check for the blood flow after temporary clips, but after I clip, yes.
So
I do use it to check the aneurysm, yes. Sometimes I put my clip, and if I want to know if the aneurysm is filling or how much is filling, then we do.
Okay, Ahmad, do you want to wrap it up?
Yep.
I think so, yeah. Please, Dr. Krisht.
Yep. Thank you, everyone. And
Thank you, sir.
And hopefully some of you may come back next week. We have the last session about pike aneurysms and pericallosal aneurysms.
Very, very good. And it's good news, Dr. Lee. We'd like to welcome the Chinese neurosurgery community. Dr. Lee is the translator. Want to introduce yourself to everybody?
Yes, my name is Li Kai. I'm a fellow of Professor Krisht, and I've been here 4 years and learned a lot. And I'm very honored to be a translator to China. And now is over 200 audience joining us. And thank you, Professor Krisht. Thank you, Professor Lawton. Thank you, Bennett.
Okay, very good. Okay, we look forward to next week. And thank you very much, Dr. Krisht.
My regards to Professor Krisht, Professor Lawton. It is very early morning in India now. And seeing Professor Krisht and Professor Lawton is like seeing God in the early morning to me.
Okay, then. We'll see everybody next week.
Bye-bye.
Thank you.
Bye.
Okay. Okay, we're off the air. Now listen, stay around if you want to network with people. And let me show you Yuha as a Yuha. Let me share with, we have a webinar with Yuha in about 12 hours. Hold on. Let me get to here.
How are things in Brazil, gentlemen?
There's Dr. D. Oliveira. He can probably answer you.
Hey, Ahmad.
Hey, how are you?
We still have a large amount of cases. We are beating the records every single day. But we are in lockdown right now. Not a total lockdown, but partially. And we are trying to give vaccine for everyone. So hopefully in the next few weeks we're getting better.
Hopefully. Stay safe, all of you.
Oh, you
Very
too.
good.
It's a great pleasure to be with you. Thank you very much.
Pleasure is ours.
Okay, Yuha's speaking in 11 hours. Actually, Yuha is introducing Professor Goel in about 11 hours. The information is on the chat. If you want to take down the link, take a look at the chat. There's the link for the Zoom if you want to come in for that.
Thank you, John. Great job.
Hey, Ahmad, I tell you, the numbers in China are big because I looked at the one of the screens, and there were 18,000 people that visited the second episode.
18,000.
Yeah, that's in China. That's like the YouTube of China. The YouTube of China. Medtion.com. Here, let me see if I can get it. Let me get it right now. Let me bring it to you. I'll show you where they put it in China.
John, have you started opening fellowship posts in US?
Okay, hold on here. Let me. Oh, well, I guess you guys are off already. Webinars with the masters. No, I guess they stopped broadcasting already. Well, okay. Let me see if.
Yeah, I saw it. You sent it to me.
Yeah, that was it. Yeah, that was it. And most of the time we don't see those numbers because it's a Chinese website.
Okay, you are getting there. Thank you, everybody.
Yeah, we got it. Welcome, everybody. And you can hang around if you want to network. Does anybody want to introduce themselves to?
John, have you started opening fellowship posts there in US Has the post been opened? Can we apply for fellowships?
Where?
In US, like for cerebrovascular?
Yeah, the best way is go online and meet people, like right now, like what you're doing. Like exactly, that's the way you do it. And perhaps someone might help this gentleman with his question. It's pretty broad question, right? Fellowships in US.
Hey, gentlemen, see you next week. I need to sign up.
Okay, thanks, Aman. Thank you. Thank you. Just network with people like you're doing now, and asking questions like you did. You know, people are going to remember your name when you answer. You know how it is.
Yeah,
in the neurosurgery community, they want to give you a recommendation, but they want to get to know you a little bit, you know, by talking and saying, hey, this is my face, this is me, you know, and I want to do a fellowship.
Yeah,
they were in the same place when they were young, when they were trying, they were in the same position as you're in, trying to meet people and get recommendations and network.
Thank you, Joe. Thank
you.
Yeah,
come to these conferences and meet people.
Yes.
Anybody else want to introduce? How's the day? Are you there? Are you there? Or you can't talk now. Okay. Dr. McAdam from Uruguay. How you doing? You still there?
Still here.
Oh, qué bueno. Qué bueno. Tenemos congresos en español también.
Yes, we have.
Yeah. ¿Le gusta el congreso? Tú entiendes todo, ¿verdad?
Yes, I do. Yep.
Oh, good. Muy bien. Hay otra persona.
There are a couple of colleagues from Uruguay.
Where? ¿Dónde están? ¿Está aquí?
Yeah.
Okay, quiero introducir, si ellos quieren, para decir hola a una comunidad internacional. Ay, Carlos, yo he visto Carlos antes, Carlos Alberto, yo he visto en otros congresos. Y Omar, Abacar, Boris, Lucia. Ok, algunas veces muy callado, la gente quiere estar anónimo. Ok, tengo que ir. Y venga, come to the UHA if you want. It's in about 10 hours. Okay? Okay. Buenas noches, todo. Good night, everybody.
Thank you, John.